Hello everyone, welcome back to my video. In this video, I am going to talk to you about premature rupture of membrane. The meaning of the terms pre means before time, mature means it is developed, rupture means it is breakage, membrane means it is a layer. So premature rupture of membrane. Myself, Gideani Thomas, working as a nursing tutor in Triple M College of Nursing. What are the objectives of this video? At the end of the session, you will be able to define PROM, know the incidents, list the etiology and clinical manifestations, enlist the investigation and explain about the nursing management of PROM. Introduction. There are mainly two membranes of the uterine sac. You all know it is chorion and amnion. Amniotic fluid, it is secreted by the amnion. It covers the placenta and umbilical cord. Amniotic sac is filling with the amniotic fluid. This fluid provides protection to fetus and function as cushion of fetus. This fluid allows the fetus to move freely in the uterine cavity. It equalizes pressure and protects the fetus from jarring and injury and maintain constant temperature for the fetus and provides small nutrients. Normal amniotic fluid volume is 1 liter at 38 weeks of gestation. What are the definitions of premature rupture of membrane? Spontaneous rupture of the membrane anytime beyond 28th week of pregnancy before the onset of spontaneous uterine activity resulting in cervical dilatation is called pre-labor rupture of membrane. Next is the rupture of membrane occurs beyond 37 weeks but before the onset of labor. It is called premature rupture of membrane. Next, it is occurs beyond 37 completed week. It is called preterm premature rupture of membrane. And next one is the rupture of membrane for more than 24 hours before delivery is called prolonged rupture of membrane. These are the some of the definitions of premature rupture of membrane. The incidence, it is very less, occurs approximately only 10% of all pregnancies. It can be a term or preterm. In that, premature rupture of membrane affects only 5 to 10% of all pregnancies. Preterm premature rupture of membrane affects 3% of all pregnancies. The incidence is very less. What are the causes of premature rupture of membrane? In majority, the causes are not known. Some of the possible causes are increased friability of the membrane, decreased tensile strength of the membrane, polyhydramnion, cervical incompetence, multiple pregnancy, infection. In the infection, chorioamnionitis, urinary tract infection or lower genital tract infection. And cervical length, it is less than 2.5 centimeter and prior preterm labor and low BMI. It is less than 19 kg per meter square. These are some of the causes for premature rupture of membrane. The diagnosis are the only subjective symptom is escape of watery discharge per vaginum either in the form of a gush or slow leak. Sometimes it is often confused with hydrodia gravidarum, that is a state where periodic watery discharge occurs probably due to excessive decidual glandular secretion. And second one is the incontinence of urine, especially in later months. Sometimes it is confused with the premature rupture of membrane. What are the confirmatory diagnoses? First one is the speculum examination. It is done taking aseptic precaution to inspect the liquid escaping out through the cervix. Second one is to examine the collected fluid from the vaginal pool for detection of pH by litmus paper. If the nitrosin paper, it turns from yellow to blue at pH more than 6. The normal pH in pregnancy is 4.5 to 5.5. Then to note the characteristics. And third test is amnesia, that is a rapid immunoassay is accurate. Then fourth one is ultrasonography is to be done not only to support the diagnosis but also to assess the fetal well-being. Digital vaginal examination should be avoided during pregnancy. These are some of the investigation we have to do. Full blood count, C-reactive protein, that is CRP, urine for routine analysis and culture, high vaginal swab for culture, especially for group B streptococcus, then vaginal pool for estimation of phosphatidylglycerol and LS ratio, ultrasonography for fetal biophysical profile and cardiotocography for non-stress test. These are some of the investigation for PROM. What are some of the complications? The dangers are, the implications are less serious when the rupture occurs near term than earlier in pregnancy. In term PROM, labor starts in 80 to 90% of cases within 24 hours, the labor will start. PROM is one of the important cause of preterm labor and prematurity. Chance of ascending infection is more if the labor fails to start within 24 hours. Liquid get infected and fetal infection supervenes. Then cord prolapse, especially when associated with a malpresentation. Continuous escape of liquor for long duration may lead to tri-labor. Placental abruption, fetal pulmonary hypoplasia, especially in preterm PROM, is a real threat when associated with the oligohydramnion. Next is neonatal sepsis, RDS, IVH, and NEC in preterm PROM. And perinatal morbidities, cerebral palsy, are high for PROM. What are the maternal complications of PROM? Chorioamnionitis, placental abruption, retained placenta, endometritis, maternal sepsis, and even death. These are some of the complications for mother. The nursing assessment. First is history collection. In the history collection, we have to take all the previous labor history, maternal illness, everything we have to take. Physical examination, head to foot assessment, obstetrical examination, and vaginal examination. These are the nursing assessment. The preliminaries of the management is aseptic examination with a sterile speculum is done, not only to confirm the diagnosis but also to note the state of the cervix and to detect any cord prolapse. Then vaginal digital examination is generally avoided. Patient is put to bed rest and sterile vulval pad is applied to observe any further leakage. Once the diagnosis is confirmed, management depends upon the gestational age of the fetus, whether the patient is in labor or not, any evidence of sepsis, and prospect of fetal survival in that institution if delivery occurs. Maternal pulse, temperature, and fetal heart rates are monitored every 4 hours. What is the management of term PROM? If the patient is not in labor and there is no evidence of infection or fetal distress, she is observed carefully in the hospital. Generally, in 90% of cases, spontaneous labor ensures within 24 hours. If labor does not start within the stipulated time, there are reasons not to wait. Induction of labor with oxytocin is commenced for with cesarean section is performed with the obstetric indications. This is a management for term PROM. If it is a preterm PROM, the main concern is to balance the risk of infection in expectant management while pregnancy is continued versus the risk of prematurity in active intervention. Ideally, the patient should be transferred with the fetus in utero to a unit able to manage preterm neonates effectively. Use of antibiotic in the management. Prophylactic antibiotics are given to minimize the maternal and perinatal risk of infection. Intravenous ampicillin, amoxicillin or erythromycin for 8-48 hours, followed by oral therapy for 5 days or until delivery is recommended. Pelvic rest and antibiotic help to seal the leak of spontaneously and reduce infection. And use of corticosteroids to stimulate surfactant synthesis against RDS in preterm neonates is advised. As such, PROM alone may accelerate fetal lung maturation. However, combined use of antibiotics and corticosteroids has reduced the risk of neonatal RDS, IVH, and NEC, BPD, and PDA. Tocolysis, progesterone therapy, cervical cerclage in the management of PRO is not recommended. According to the gestational age, we have to do the management. If it is a before 23 weeks, termination may be an option depending on the gestational age, amount of fluid loss, etc. Initial bed rest to encourage resealing. Look for infection, abrupt or labor. Serial ultrasound to evaluate oligohydramnion and pulmonary hypoplasia. If so, induction with oxytocin, PGE1 or PGE2 or dilatation and evacuation. If no pathology, consider conservative management. If it is 23 to 31 weeks, conservative management. Serial evaluation for amnionitis, labor, abruption, fetal well-being. Bed rest is to recommend for resealing, administer corticosteroid and antibiotic, delivery if any pathology. Deliver at 34 weeks if stable until then. If it is 32 to 33 weeks, document fetal pulmonary maturity with concurrent antibiotic followed by delivery after 24 to 48 hours. If mature expeditious delivery, antibiotic for GBS prophylaxis unless non-negative. And 34 to 36 week expeditious delivery intrapartum antibiotic. I'm summarizing my topic. In this video, we've seen that what is the definition of premature rupture of membrane. So you all know that it is a spontaneous rupture of membrane any time beyond 28th week of pregnancy. It is called a premature rupture of membrane, and we've seen the incidence and causes, diagnosis, what all are the investigation and complications, maternal complication, and then the management. So these are all about the premature rupture of membrane. These are the references of this video. Thank you all for watching this video.